Kia ora tato. We're going to think about the pathology of the upper GI tract today. You have learned about the upper GI tract before in ELM. You had these two learning sessions, one on cirrhosis and ulcer and the other on IBD. Previously, you have learned about peptic ulcer disease and something about inflammatory bowel disease. Here are the notes from your ELM lectures. I'm not going to repeat this information, but here it is in case you need to revise. And some more. So what is there left to learn? So we need to learn about disorders of the esophagus. We need to know about some disorders of the stomach that we haven't covered yet, and a bit more about Helicobacter and ulcers. And we need to know about disorders of the duodenum. Okay. I know that you learned a bit about esophageal varices, lots about Helicobacter, and so we're going to concentrate on the other things. Let's start with the esophagus and Mallory-Weiss tears. So what is a Mallory-Weiss tear? A Mallory-Weiss tear is this: a tear in the esophagus near where it joins the stomach, and it tears through the big veins that are there. That sounds like trouble. What causes it? Often retching or forceful vomiting will cause it. And it's often associated with alcohol abuse, hiatus hernia, chronic reflux, or eosinophilic esophagitis. Of course, when those big veins are ruptured, people get hematemesis, vomiting blood, melena, passing blood, PR, and with all that blood loss, they get lightheadedness, syncope, hypotension, and shock. Mallory-Weiss tears have a overall mortality of 20%. Serious. It's particularly a problem when people have varices, because those varices, they are big and dilated and they easily tear. So Mallory-Weiss tears are most serious in people with cirrhosis, and with the continued alcohol imbibation by the patient, they are, well, not a common cause of death, but they're a serious cause of death in people with chronic alcoholism. So let's have a think of esophagitis. So we're going to vindicate this. Well, you're going to vindicate this. I'm going to tell you to pause the video like I would if I was in the lecture. I would pause my lecture, and I want you to vindicate esophageal disease so you get an idea of the scope of it. Off you go. Pause the video, please. Moving on to the next slide, you have your vindicate list. These are the most common causes of problems with the esophagus. The esophagus. Reflux esophagitis, often associated with diet and alcohol. Medication-induced esophagitis, infectious esophagitis, allergic/eosinophilic esophagitis, that would come under immune, and physical injury, radiation and chemotherapy associated esophagitis. Eosinophilic esophagitis is increasing in number. It has increased a lot in the past 20 years. It's immune antigen driven, so people are allergic to something. Often it occurs in people with asthma. It's characterized by a peripheral eosinophilia, hypersensitivity, and high levels of IgE. It's particularly prevalent in children and occurs in younger adults. It occurs in men more than women, which is unusual for an immune disease, but this isn't an autoimmune disease. This is an allergy-driven disease. So let's think about how you might explain the pathogenesis of eosinophilic esophagitis. So, landscape, eosinophilic esophagitis is a response to food or environmental antigens causing inflammation of the esophagus. In eosinophilic, this is number 2, in eosinophilic esophagitis, epithelial cells function as antigen-presenting cells. 3, recruit activated neutrophils, recruit activated eosinophils that release TGF-beta for promote local inflammation and injury. 5, cause remodeling, fibrosis, and smooth muscle dysfunction. In other words, people eat food, the epithelial cells take it up, they present it as antigen-presenting cells, and initiate an eosinophil-driven inflammatory cascade. In children, it presents as vomiting and regurgitation with nausea and epigastric pain, and in adults with dysphagia, and this is important, bolus food impaction, right? So what other things give bolus food impaction? Strictures, cancer, but eosinophilic esophagitis causes contractile dysfunction, all the inflammation. And so you get this characteristic food bolus obstruction, impaction. Okay. Next, esophagitis. Pill esophagitis. So pill esophagitis is when people swallow a pill like a non-steroidal and it gets stuck. And as it gets stuck, it erodes the mucosa, forming a discrete ulcer. Here it is. Here are the pills. And they often get stuck where the esophagus narrows as the aortic arch passes by it. This is the 2 non-steroidals. This is the aortic arch. This is them about to form an ulcer. Candidal esophagitis. So it often happens in people who are immune compromised. Here is the classic white cheese curd that occurs in all candidal infections. It happens in vaginal candida infections, happens in esophageal candidal infections. It's the candida organisms growing in a mat of sloughed off material. And it's been so bad that it's formed an ulcer because it's like the inflammation associated with it has eroded through. Next, let's think about reflux as a cause of esophagitis. Reflux, so common. And I'm sure you've all had the feeling of heartburn. This is your esophagus. I just can't say it today. Esophagus being inflamed. So let's think of the pathogenesis. Let's think of the steps again. Right, landscape. So gastroesophageal reflux is caused by reflux of gastric, usually, occasionally duodenal contents into the distal esophagus. It is caused mostly by decreased, step 1, decreased pressure in the lower esophageal sphincter, which can be caused by a variety of things, but is most often caused by intra-abdominal pressure, okay? Pregnant women, people who have a high mass have increased pressure in the abdomen. That can also be caused by hiatus hernia, delayed gastric emptying, or just a structurally defective lower esophageal valve. When that happens, the contents reflux into the lower esophagus. Man, I'm having trouble with esophagus today. Things that make it worse are smoking, alcohol, and caffeine. So what happens when it gets there? Sorry, here we go. The acid causes a direct injury to the mucosa, which means that acute and chronic inflammatory cells migrate into the mucosa and the underlying submucosa. It can become so bad that it causes ulceration, and so bad that sometimes it can cause deep ulceration. It's really common. So reflux is like a third of us will get reflux. Gastroesophageal reflux disease happens in less of us because the esophageal mucosa is really good at repairing itself. And so we don't develop the chronic inflammation and ulceration. Down the endoscope, it looks red because, of course, it's inflammation. About 70% of reflux will have a normal endoscopy, non-erosive disease, and only a small number of people will actually develop the gastric erosions. Treatment is the hard way: weight loss and diet and lifestyle modification. Hard. This is why omeprazole is so commonly used in the population, because it's a common disease and people use protein pump inhibitors like omeprazole to treat reflux. If it is not treated, then it can lead to ulceration, as I've mentioned, and the ulcers can heal by fibrosis, leading to a stricture, which can mimic cancer. If it goes deep, it can erode a vessel and cause hemorrhage. And of course, long-standing reflux can cause aspiration. So people reflux at night when they're lying down, and that can be aspirated into the lungs. But it is the long-term complications that are most feared, and that is adenocarcinoma of the esophagus via Barrett's esophagus. Let's have a think about what Barrett's esophagus is. So Barrett's esophagus is a complication of reflux. If in chronic reflux, the squamous epithelium in lining the esophagus turns into columnar epithelium. This is a metaplasia. It is the poster child of metaplasia, where you get chronic inflammation in the esophagus. The squamous epithelium becomes glandular. And then that glandular epithelium undergoes intestinal metaplasia, which is step one on the way to becoming unstable, gaining mutations, and becoming malignant. Barrett's esophagus is usually found in people over the age of 50 years who have high risk of reflux, like increased abdominal pressure from high weight. Okay. It's relatively uncommon, so remember that while reflux is common, gastroesophageal reflux disease, as in chronic inflammation, is relatively uncommon. Of those, about 20% might get Barrett's esophagus, and much fewer of those go on to develop dysplasia within Barrett's esophagus and continue down the carcinoma sequence. The best study was in Sweden. It showed that 1.5% or so of the population would have Barrett's esophagus, whereas a third of us will have reflux. So it can help be prevented by omeprazole. So antacids can be used, but mainly people use omeprazole. And the fear is that once the intestinal metaplasia in Barrett's esophagus is established, it will then go on to form cancer. So dysplasia, if it doesn't progress, can just sit there and do no harm. But if it continues to accumulate mutations, then it will progress to cancer. The progression rate depends on the grade of the dysplasia, with high-grade dysplasia, of course, having the highest progression to cancer. How is it treated? It is removed, right, by ablation, or by radiofrequency ablation, cryotherapy, or laser can remove Barrett's esophagus if it is dysplastic and at risk of cancer. Okay. So now this is where you pause the video and do a bit of thinking to make sure it has all sunk in. I want you to pause the video and then use the LIPS protocol to try and explain it. If you're at home and you've got a cat, tell the cat. If you prefer writing things, write it down. If you are not going to do either of those, just pause the video, look me in the eye, and explain it to me. Okay, coming back again. Hopefully, if you wrote it down, you would have written something like this. So if you remember, you're explaining it to a patient. So we want to use patient language. Imagine the patient sitting there, you've just come out of gastroscopy, and you've got to explain it to him. Barrett's esophagus is a change in your cells lining your food tube, the esophagus. It's more common in people who have acid reflux. It's important for it not to progress further, as very rarely it can progress to cancer. We want to reduce your reflux symptoms and keep your esophagus healthy by managing your heartburn and acid reflux with a medicine called omeprazole. And the important bit, we will keep an eye on it by having further endoscopies in the future. And you might want to include some red flags after that. If you develop difficulty swallowing, a feeling of something being stuck, like food in your esophagus, or any bleeding from your, any kind of vomiting with bleeding, then you should come back and see us straight away. Okay. So let's have a look here. Esophageal cancer. So we've mentioned that there's adenocarcinoma in the esophagus. Adenocarcinoma makes up the majority of cancer in the esophagus, and it has been increasing in incidence. Squamous cell carcinoma is the other kind of esophageal adenocarcinoma, and it is decreasing in incidence. So why is the rate of esophageal carcinoma rising? Have a bit of think. Brainstorm with the cats, people next to you. Why? Just pause the video for a moment and think why. What did you come up with? What did you come up with? I think because it's related to acid reflux, right? I think it's due to several things. I think that it's due to people having increased weight and increased alcohol. And so there is an increased tendency for reflux, and therefore an increased tendency for Barrett's esophagus. I also think that it's due to lack of Helicobacter. Remember, Helicobacter causes gastric atrophy. And if you've got gastric atrophy, you don't produce acid. If you don't produce acid, you don't get Barrett's esophagus. So we've cured Helicobacter, our stomachs are more acid, and we have more reflux. Okay, what did you think? Let's think of adenocarcinoma of the esophagus. There's that picture there of this rolled edge ulcer, which is typical of carcinomas of the esophagus and stomach. So adenocarcinoma of the esophagus, remember, we're talking about adenocarcinoma now. It arises in the lower third of the esophagus in association with Barrett's esophagus, because this is where the reflux is. Often it's silent until it presents with difficulty swallowing, which is a problem because it presents late. And by the time people have had dysphagia or retrosternal pain, then the cancer is quite advanced. If it is detected early on those screening endoscopies that you were recommending to the patient a moment ago, it can be cut out locally or ablated. But if there is a high stage lesion, then chemoradiation can be used, and there are some dramatic surgeries that can be done where the esophagus is partially replaced. Still, the survival rates remain below 20%, and Mari experienced both higher rates of incidence of adenocarcinoma and a higher mortality from it. Let's think briefly about squamous cell carcinoma, the less common cancer. So it is present in the middle third of the esophagus. It is due to irritation of the squamous epithelium by alcohol and tobacco use. Onwards. So I've talked about reflux and its complications. Now we're going to think of another kind of, now we're going to move to the stomach. All right, this is the stomach. Off we go. These are the definitions of where bits of the stomach are, just as a bit of a reminder about the anatomy. And this is a reminder of the different parts of the stomach. Okay, we have the antrum, which is mainly mucus secreting and has mucus secreting glands, and the body, which is full of glands that produce acid and enzymes. So what is chemical gastritis? So chemical gastritis, also known as reflux gastritis or reflux gastropathy, is where bile salts reflux back from the duodenum into the stomach and damage the antrum. Okay? It can also be due to some other things like alcohol, corticosteroids, some chemotherapy. What happens is we get hyperplasia of the superficial foveolar parts of the duct. And we can see damage. Generally, it's diagnosed because people come in because they have gastritis symptoms. It's not helped by omeprazole because it's not due to acid. And so they get it diagnosed on endoscopy. It does not usually progress to cancer. Here are notes again from your ELM 3. Remember these notes? We know a lot about Helicobacter. Here they are. So Helicobacter, these little spirochetal organisms living in the mucus are on the surface and the gastric glands. I'm just going to remove my little thing here. Can you answer these questions? So these are key questions that I'd like you to pause now and check, because you have been told this from ELM, whether you still remember these things. If you don't, then it's time that you did some revision. Because I'm not going to revise it because like, you know this. If you don't know this, then you can email me and I will send you things where you can learn it. Okay. Can you answer these questions? Try it now. I'm going to pause the video and try and answer them. Just answer them as one-liners, okay, one-liners, and pause the video. Moving on. This is what it looks like. Helicobacter causes a ton of inflammation in the interstitium and in the glands as well. So peptic ulcer disease, you know a lot about this too. We're not going to go through all this detail either. You know this, read your notes. Peptic ulcers. So here are the key questions that you will be asked about peptic ulcers and you need to know. Can you answer these questions? If we were in the lecture, I would get you to talk to them about it and ask me, but we're not. So if you're not able to answer them by looking at your previous notes or a quick look at Robin's, then email me. Pause the video, answer them now. Okay. So one of the things that I do like to do is think about pathogenesis, because pathogenesis is the key to understanding lots of things. So let's think about pathogenesis of these diseases. So here we go. Right, peptic ulcers. So peptic ulcers come in two varieties. They come in duodenal ulcers and they come in gastric ulcers. And these have different pathogeneses. I was just thinking, is that really plural of pathogenesis? Anyway, here we go. So with gastric ulcers, what happens? So mainly Helicobacter, particularly the ones with the virulence factors, and some host factors and other environmental factors like smoking and alcohol, cause gastritis, right? Now, this can do two things. It can like wipe out all the glands and cause low acid, right? That causes atrophic gastritis, yeah, and gastric cancer. We'll come to that in a minute. Or it can be in the antrum, like this is the whole stomach affected. It can just be in the antrum. And if the antrum's affected, it sends signals up into the body and says, hey guys, you got to produce acid. And the extra acid can cause peptic ulcer disease. So in particular, it causes duodenal ulcer. Why? Because of acid dumping. Okay, so Helicobacter pylori will cause partial antral predominant gastritis, which causes increased acid production, which causes duodenal dumping. Okay, here's the little cycle here. That causes duodenal ulcer. So how are gastric ulcers formed? Right, gastric ulcers are formed because of vulnerable mucosa. Okay, so the mucosa can become vulnerable because of non-steroidals or Helicobacter. They can act together. All right, so what happens is inflammation in the mucosa can reduce mucus production and make it vulnerable to damage and attack. Non-steroidals, as you probably know, can have a topical effect, cause direct damage, or they can have a systemic effect, leading to decreased mucus, reduced bicarbonate, blood flow, decreased cell restitution, and lots of neutrophils, while here on this side, the Helicobacter is causing lots and lots of inflammation. And together, they will cause mucosal damage and ulceration from normal acid levels plus pepsin, which is, of course, a protein that dissolves, sorry, an enzyme that dissolves protein. So gastric ulcers have normal acid levels and they have erosion of the mucosa. And duodenal ulcers are associated with high acid levels due to things, Helicobacter in the antrum, causing excess acid. I hope I've got that through to you. This is an important distinction because they will cause different symptoms and need different treatment. Okay, let's think about cancer. I'm always thinking about cancer. How does Helicobacter cause cancer? Helicobacter is the main cause of chronic atrophic gastritis. And with chronic atrophic gastritis, the chronic inflammation causes metaplasia from the normal, particularly foveolar mucosa, into intestinal type mucosa. And this is the first step into the mucosa becoming genetically unstable. Chemical gastritis, which we've mentioned, is an uncommon cause. And then there's a whole lot of other gastritides or gastritises that can cause chronic atrophic gastritis, but mainly Helicobacter. Chronic atrophic gastritis with intestinal metaplasia causes, is genetically unstable, mutations accumulate, dysplasia occurs, there's an in situ phase, and then more mutations lead to malignancy. This is, again, the classic adenocarcinoma sequence that was similar to the esophagus. Gastric cancer has decreased in incidence as we've got on top of the Helicobacter and can now effectively treat it. What does it look like? Again, it can have several growth forms. This one here, right, forms this horrible big exophytic necrotic mass. This one here is forming a sclerosing type ulcer. In places that have very high gastric adenocarcinomas, there are screening programs, and they can be very effective at reducing the outcome for that. So Japan, for example, has a screening program and detects gastric carcinomas early. And so there is a high survival rate because they can be locally resected. But if a patient has advanced gastric cancer, the outcome is poor and people die within about 2 years. In gastric adenocarcinoma, there are two main types. The first is the standard adenocarcinoma, where we have infiltrating glands. Okay, so, you know, we've said this before, we have glands lined by pleomorphic, mitotically active hypochromatic cells that invade from the mucosa through the gastric wall and into the lymph nodes. And this is called standard gland-forming intestinal intestinal type gastric adenocarcinoma. But there is another type of gastric adenocarcinoma, and this is the signet ring one. Why signet ring? So I've only got a wedding ring on. I don't have a signet ring, but signet rings are those ones where you have, you know, a ring and then there's a flat plate on the top here where a signet lies. And so this is meant to be the outer part of the ring, and this is meant to be the signet part, and inside is a blob of mucus. And these are bad news. So they just spread so easily. The cells are really discohesive. Once they form, off they go. Right, so molecular classifications of gastric cancer. Why is this important? It is important because it influences the chemotherapy. So this is our job. Someone has gastric cancer, they get a biopsy, we will diagnose it, but we will also do molecular studies on it so that their treatment can be optimized. Do you need to memorize this slide? No, do not memorize this slide. What you have to do is understand the principle that gastric carcinomas have molecular drivers, and those molecular drivers can be targeted by chemotherapy. And on the bottom of the report, you will see molecular information. And so the oncologists will interpret this and they will choose the correct chemotherapy for it. You might notice, for example, that on the bottom of the report, what we often do is we do HER2 staining. Okay, some gastric cancers are driven by HER2 and get a different treatment to ones that are driven by PIK3CA or have PD-L1 targets. Don't memorize the slide. So very important is hereditary diffuse gastric cancer. About 10% of cancers have familial clustering from a variety of genes, and of these, about 1 to 3% have hereditary diffuse gastric cancer because of mutation in the CDH1 gene, which was first described in Maori families in New Zealand, but it has now been found in a wide range of ethnic groups. People with this gene, which is inherited in an autosomal dominant fashion, have a cumulative risk for cancer at 80 years. So that means by the time people are 80, there's like 70 to 80% chance that they will have had this deadly gastric cancer. So what do? We can try endoscopic surveillance, but it's not so good because by the time these cancers have developed and these little signet ring cells can be seen on the endoscope, they are off, right? They have spread already. Bad news. And plus, it can occur anywhere in the stomach. So people who carry the gene are offered gastrectomies and reconstructions so that they can find so that they can survive. Here we go. This is what we get in those people. We get stomachs, and we've opened it up, and we sample every single bit of stomach to find cancer. Here's a typical one where we've mapped out all the biopsies. And here in these red areas, we found very small gastric cancers developing in a 30-year-old. And here we found in situ carcinomas developing. That's the end of gastric carcinoma. Now we are going to briefly think about celiac disease. So celiac disease is from duodenal ulcer, the thing that you need to think about in the duodenum. Here we go with celiac disease. All right, so celiac disease is an immune disease. I'm just going to move my little photo again. So here we go. This is the normal duodenum here, where we've got these nice long villi which absorb stuff. Okay, in celiac disease, what happens is there is an immune reaction where lymphocytes infiltrate the epithelium at the top of the villi and destroy them, making the surface flat. Why? Why does this happen? So it happens in people who have a genetic tendency. So people with certain HLA groups have an increased tendency to get celiac disease. Not everyone with these immune groups will get celiac disease, but they're pretty much required in order for it to develop. And then there's exposure to dietary gluten, and antibodies are generated. Okay, and the antibodies activate the T cells, and the T cells do the damage to the mucosa. It presents with these symptoms. It can occur at any age. We see it in children. We see it in adults. And the blood test for it is the serum TTG, okay, which is very much specific and sensitive. It is improved with a gluten-free diet. You get some clinical improvement in about 48 hours of a gluten-free diet, and all the histologic changes disappear. The complication of this disease, if it's not treated, apart from having a terrible, terrible life because of your diarrhea, malabsorption, steatorrhea, abdominal pain, etc., is that a few people develop a lymphoma based on the overstimulation of these T cells. Okay, so here we go. This is someone with celiac disease. They have got very, very flat mucosa now, with lots and lots of lymphocytes in it. All those nice villi are blunted. Now, it's not the only cause of a blunting of the villi, okay? So, of course, if you dump acid in there in peptic duodenitis, it will damage villi and cause them to be flat. Non-steroidals, tropical sprue, due to, happens at the distal small bowel mostly, and it's due to people acquiring aerobic bacteria that overproliferate, and some other infections. So here we go. This is Giardia. Giardia, don't drink wild water that's been contaminated by animals who have giardiasis. Possums, you're the bad guys, because you can acquire Giardia, fortunately easily treated. Okay, that brings us to the end of the lecture on upper GI and duodenum. Do the homework, because I think in the homework you will encounter maltomas. These are not as exciting as you think. They're nothing to do with malt or malt drinks. They're a B-cell lymphoma that is caused in the mucosa associated lymphoid tissue by Helicobacter. That is a great exam question and often asked, so do your homework. See you later.